All right, good morning, everyone. I want to welcome everyone to our inaugural webinar series, where today we'll talk about addiction treatment behind bars, what kind and who decides. As you all know, it is National Drug Court Month, and our team at Behavioral Health Group is so fortunate to have some amazing team members and partners who have come together for this important discussion. Before I introduce our speakers, I want to run through a few housekeeping items with everyone. We will have two more webinars on May 23rd and May 25th. If you haven't registered yet, you will get a link to do so in our follow-up email after today's session. We are going to open it up for some question and answer time at the end today for about 10 or 15 minutes. During the presentations, we will have you all on mute. So if you have questions, please put them into the chat. Our team is going to be monitoring for those so that we can make sure we bring those up during the Q&A. We're also going to be live tweeting throughout the event. So if anyone would like to follow along on Twitter, our Twitter handle is BHG_recovery. All right, so now I'm going to introduce you to our speakers. First, we're going to hear from Carl Anderson. Carl serves as the administrative manager for the Arapahoe County Sheriff's Office in Colorado. Carl is passionate about addressing substance use disorders, including opioid use disorders, as evidenced by implementing a variety of Narcan programs throughout the Arapahoe County Sheriff's Office. In June of 2018, Carl played a significant role in implementing a medication-assisted treatment program at the Arapahoe County Detention Facility. He understands the importance of implementing these types of programs as they are best practice to ensure quality patient care. Carl is also a certified correctional health professional through the National Commission on Correctional Health Care, or NCCHC. The NCCHC provides standards that ensure quality patient care is being delivered within the correctional setting. Carl understands the importance of these standards not only for ensuring quality care during incarceration, but also when they are re-entering the community after release. Throughout his career, Carl has proven that he is passionate about public health and public safety and the strong relationship between the two. He believes that a collaborative approach is the best approach, and he demonstrates this by bringing community partners in public health and public safety together to implement programs that not only benefit patients, but the communities that we serve. Our second speaker today will be Dr. George Kaiser. Dr. Kaiser is a board-certified physician in preventative and internal medicine. He is also a diplomat of the American Board of Addiction Medicine, as well as an American Society of Addiction Medicine Fellow. While he's primarily worked in internal medicine and primary health care, he's also worked in addiction medicine throughout his career. For 6.5 years, Dr. Kaiser also worked as the medical director for the Nevada Department of Prisons. Currently, Dr. Kaiser serves as medical director of West Care Nevada, a nonprofit organization providing a wide range of health and human services in both residential and outpatient settings. He's a preceptor in internal medicine at the VA Medical Center. And for the last 12 years, we have had the great fortune of having Dr. Kaiser serve as the medical director for one of Behavioral Health Group's certified opioid treatment programs located in Las Vegas. I'm very pleased to be serving as your moderator for today's webinar. My name is Chrissy Martin. I am a regional clinical director for Behavioral Health Group. I'm a licensed addiction counselor supervisor and a licensed marriage and family therapist in South Carolina. And I've worked primarily in opioid treatment for more than 15 years. During my time at our Behavioral Health Group program in Charleston, I helped secure the contract to provide outpatient drug and alcohol treatment services to the first federal drug court program in South Carolina back in 2011. And we continue to serve in that role today. This program has served as the template for the 3 additional federal drug court programs operating in our state now. And so I'm very excited to be here today facilitating this important discussion on the intersection of drug and alcohol treatment, evidence-based practices, drug courts, and correctional settings. And so with that, I'm now going to pass it over to our first presenter, Carl Anderson.
Thank you, Christina. I appreciate that introduction and welcome everyone. Our friends near and far, I appreciate you taking time out today to listen and learn about this very important topic. I like to begin these presentations with, taking a deep breath. I ask each of you that are on here today to, be present, be engaged. Let's learn from one another and let's have some good discussions. I want to thank BHG for this, 3-day seminar that, again, as Christine said, true passion of mine as a registered nurse. I not only believe in quality patient care, but I believe in implementing programs that allow an opportunity to beat that or meet that gold standard. With that, I'd like you to take that all important deep breath, be present, be engaged. And for a moment, imagine yourself, you're living your daily life. Perhaps you or a family member or a friend is on a medication. One that we're familiar with could be insulin. It could be an anti-hypertensive med. Let's say for a moment that you make a bad decision and you come into jail and you meet with, at least in our model, you'll meet with a nurse right when you get here. Let's say that nurse explains to you that you will no longer receive your insulin or your high blood pressure medication that you've been taking for years. That's the case with MAT meds, medication assisted treatment. Not here at Arapahoe County Sheriff's Office, and very fortunately, I think we are gaining some momentum out there. But patients that suffer from substance use disorder, whether it be prescription medications, opioids, and or opioid use disorder, they are used to hearing those words, that their methadone or their Suboxone or their naltrexone, aka Vivitrol, will be stopped and they will immediately go into withdrawal. That creates a lot of anxiety for our patients. That puts them into a high risk situation. So with all that being said, I've been in correctional healthcare in some capacity for 22 years now, and very fortunately, the leadership here at the Arapahoe County Sheriff's Office, I and we share philosophies on the importance of implementing those programs, specifically medication-assisted treatment. Providing a little bit of a historical here, Narcan or naloxone is a life-saving medication that I advocate on a regular basis, that all agencies, law enforcement, community-based treatment, whether it be a hospital setting or community-based OTP, opioid treatment program, I think we need to have Narcan available. Very fortunately, in 2015, we were able to implement a variety of Narcan programs within our facility. Meanwhile, knowing that the Narcan is a lifesaver, right? If we have a suspected opioid use overdose, we can potentially save that life with the use of Narcan. All the while, we wanted to get to that root cause, and that's where our medication-assisted treatment program first began growing legs, is in the early portions of 2016, where internally we began discussions on, let's identify that root cause of somebody suffering from OUD, and let's continue their medication-assisted treatment. So we were able to finally launch a full-service MAT program in June of 2018. Next slide. So continuity of care, and we've spoken a little bit about that already, but somebody coming into our facility, it is important to continue their community-based care, whether it be that chronic care diagnosis that we've talked about earlier on, or their SUD medication, whether it be methadone, Suboxone, or the Vivitrol. And in 2018, we were able to continue that medication, verify it through one of our community-based OTPs, and our medical team here will, once verified, will continue that medication, and that's our model as we sit here today. Next slide. So I think it's important to understand what an OTP is. For those of you on the line, again, having a partner within the community, an OTP, it allows two things. One, that continuity of care coming into our facility, and then post-release as well. So I think it's important for us to understand that, when a person is incarcerated, at least in our facility here at the Arapahoe County Sheriff's Office, the average length of stay hovers right around 3 weeks for the individuals that are incarcerated here. So a lot of moving parts there where we've got to verify the dose. Sometimes we have to, as the slide indicates, we have to lean on guest dosing, which within our agreement with each of our partnering OTPs, to include obviously the behavioral health group, we can lean on other entities to verify and then guest dose our patients that we are treating here. Without that community support, our MAT program would not exist. And then the risk would be the continuity of care post-release. Our current model, and the one that has been in place since 2018, allows for that patient to be released from custody and then have a same day or next day appointment with behavioral health group. This slide here, the title of it is kind of the why, if you will, behind our MAT. Along with everything that we've already identified, the continuity of care, accidental overdose is a true risk for the folks that suffer from OUD while incarcerated. They don't realize that whether they are suffering from OUD based on prescription and or illicit opioids, they don't realize that their tolerance level has significantly decreased while they're incarcerated. So what happens is they go back to old habits. They get released, they go back to that dose that they're used to taking, and that accidental overdose occurs. And hopefully we can save their life by means of naloxone, i.e. Narcan. But oftentimes we can't save those lives. So MAT allows an opportunity, again, for that continuity of care to remain in place, and for the individual, the patient being released from custody, to continue their care without a lapse in care. Another area that I've been passionate about throughout my career is utilizing resources effectively and appropriately. And if again, if we release people that haven't had a lapse in their MAT treatment, we can avoid the misuse of resources. By example, fire and rescue, hospital setting, etc., because we're maintaining the care that they're used to receiving. Here's a kind of a glimpse. I think numbers are important. Again, the 2018, the yellow is our go live, our launch date. Again, was June of 2018. And I think it's important, and we'll talk about it in an upcoming slide, but these numbers are significant because these numbers are people that, were treated with MAT, and they did not experience withdrawal while in custody. You'll also see within that bar graph that, you see trending data that is decreasing. I'd like to point out that the numbers reflect the pandemic, and our numbers inside of our facility when it pertains to incarcerated individuals have decreased during the pandemic. So obviously there's a direct correlation to the numbers revealed here. So again, as I just said, they don't experience any type of withdrawal. We don't necessarily have to worry about them going into electrolyte imbalance that I would argue would be life-threatening while incarcerated. Withdrawal protocols prior to June of 2018, we were one of those facilities that would identify someone as an OUD patient, and we would put them on a protocol. I will say that it's not bad practice, but I certainly don't believe that it's the best practice. I think that having an MAT program will absolutely get you to the level of being that best practice model. And again, I think it's important for us to find my passion. You've heard my passion. My passion is the continuity of care, the quality care being delivered to the individuals that are incarcerated. But if we have MAT, it has a direct correlation, yet again, to decreased overtime, to decreased having security members, in our case, deputy sheriffs, being sent to the hospital setting to watch our inmate patient population. Next slide. Is diversion a concern? I would say yes. And on a regular basis, I certainly believe that medication diversion is always a concern. I use the example of Tylenol. Tylenol, most of us on this call, and I don't mean to speak for any of you, but we downplay the risk of Tylenol on a regular basis. If we administer Tylenol, to someone that has acute liver failure or any type of liver dysfunction, we potentially could be putting them at risk. So I use that example because I think it's important to just bring it home. And yes, hearing the words methadone, that can be intimidating, that can be scary. Suboxone the same, and Vivitrol, although is more controlled through an injection, a once a month injection, it is more controlled. But these are scary medications that, or can be scary medications if you hear them and we're not educated on them. I think every medication pass within a correctional facility is high risk. I think the diversion is always a risk, and it allows an opportunity for us as leaders within our organizations to provide our troops, our boots on the ground with effective training, open, transparent communication so that they're well prepared for having methadone within our facility. Just spoke on that a little bit, and I think as I reflect, and I spend a significant amount of time reflecting on decisions that I make or we make as an organization, and MAT certainly meets that criteria, and I reflect on it regularly. And one of the things that I'm most proud of is the effort that we placed into training our staff. We were very proactive about getting out there and communicating with obviously our medical team. Even behavioral health group would come in and provide proactive training to some of our medical folks that were not that familiar with MAT. We would be out there and meeting with our deputies, our sergeants, our lieutenants, and make them aware of the program, but also receive their buy-in. And if they're educated and trained on it, then it's not foreign. And by the time we rolled out in June of 2018, I really do feel confident that we did a great job communicating with our staff proactively. This slide here is a little bit busy, and I apologize for that, but it gives an idea on what to anticipate as far as a workflow when it comes to MAT. We did have to change a few things when we went live with our MAT program, and one of those areas was our intake process. We had to change our forms. We had to be very specific on asking our inmate patient population coming into our facility whether or not they were being treated for or with MAT meds, and which OTP was providing that treatment for them. So it was a simple change to the form. They meet with the nurse. They verify the MAT med, the dose, obviously. And then we were able to implement a model that would allow and does allow each of our OTPs to make deliveries usually on a weekly basis, again, depending on the sentence of our inmate patient that is participating in the MAT program. But it's a very simple process. It adds a step or a couple of steps, but it certainly can be done. Next slide. Yeah, I firmly believe it. You can do it. I think having those, again, the community support is huge. Having the support of behavioral health group, I can't voice how important that partnership is to us as an organization. I think it's important that we're open to it. And I will tell you, I'm sitting here, I'm so excited that we're all together and we're talking about MAT. That's one of the first steps, right? We've got to have an open dialogue. And here we are, and we are doing it. I'll tell you what, 10, 15 years ago, this conversation doesn't happen. So I appreciate you all taking that first step and realizing that, we can make your goal of having MAT within your facilities or within your agencies. We can make that thing come to fruition, and it just takes a little bit of passion along the way. I argue, and you can keep this slide up. It's okay. We don't need to go back. I think that it's important. We talk about public health and public safety. In my vision, again, correctional healthcare has been the definition of my RN career. But there is a very direct correlation to public health and public safety. And if we're able to implement MAT at all of our facilities across our country, I do believe the direct correlation to a safer environment. Number one, a safer patient, a healthier patient will absolutely lead to a healthier family unit, it'll lead to a healthier community that we all live, play, and work in. And I think we can see a decrease in criminal activity again by decreasing that risk of them chasing their prescription or illicit opioid of choice. Again, thank you.
Thanks, Carl. I think you're so right about that just ripple effect. It's really not just about serving the patient at that moment in time. It has so much greater value beyond that. All right, we're going to pass it over now to Dr. Kaiser.
Thank you, Chrissy. And Carl, that was a great presentation. So I think what we're going to do now is just kind of go in a little bit and look at what MAT is, go over the medications, go over the reasons that kind of back up exactly what Carl said, that this is a timely therapy, this is an important therapy, and this is, we're certainly using it outside the correctional system, and I think it's well past the time that we should consider it. So when we look at the United States, I'm talking to people in the correctional and the court system, and I think you're already aware that we incarcerate more people in the United States than other places in the world, and that's about 937 per 100,000 people. Of those, about 33% of all heroin users usually go through some system, either a jail or a prison yearly. Of those who are incarcerated, 75% of them relapse within 3 months of release. Unfortunately, this causes a high death rate, as Carl already mentioned, that because of various factors, including fentanyl, loss of tolerance if you're incarcerated, not on medication, that the person is high risk. There's a 40 times increased risk of death in the first 2 weeks after release from incarcerations. And so that's really an area I think that we should target, because it's pretty identifiable, and I think there's a corrective measures that we can use. So unless the inmate is on medication at release, they're going to have some trouble. They may have trouble accessing the healthcare system. They may have trouble. Hopefully, Carl and others gave them Narcan at discharge, but they're going to have trouble getting on medication. And so, one of the things about addiction care is the more seamless the process, the more there's a warm handoff instead of kind of a delay, usually the better outcomes. And there have been some controlled studies, which is kind of our words for the scientific method that we use to demonstrate whether things are useful or not useful. But there are controlled studies in the state of Rhode Island. They made the entire state provide MAT from beginning to end of the incarceration period, and they've shown by studying the post-incarceration death rate that they can reduce that. Next slide. So we do know, there are people who don't use opiates daily. There are some people that use them infrequently. On the other hand, they're one of the most addictive drugs in the world. These are the criteria for opiate use disorder. And we really need to think of addiction as a biopsychosocial disease. So addiction affects you biologically, but it also affects you psychologically. And so you kind of think of it as the brain being hijacked by the opiates. I've never met an addict who had any intention of being an addict. On the other hand, once you're addicted, again, your brain is hijacked. Number 10 and number 11 have a little asterisk there. So if a doctor gives you narcotics and prescription, and you take the prescription as prescribed, that's not opiate use disorder. That's a dependency on opiates. You will have a withdrawal. But again, if you don't have some other risk factors, which we'll talk about in a minute, you just go through the withdrawal. And sometimes after that, people that have been on opiates who aren't susceptible to addiction try to avoid them in the future. Next slide. So for treatment of opiate use disorder, I just wanted to kind of go over what the process is. And so drugs like heroin, oxycodone, your pain pills that you might get from the doctor, or you might get off the streets, those drugs have a short half-life, and so they don't last very long. What they do is they have an ascent in the blood level, and during the ascent, the person might feel some euphoria, they might feel some pleasure, they might feel high or intoxicated. If they take excessive amounts, obviously they might stop breathing and have an overdose. You can use opiates orally, you can inject them, you can smoke them, or you can snort them. And we do see some people smoking and using nasal heroin because they feel that that's less dangerous than the injection. When the drug descends, so it goes up quickly, and then because it has a short half-life, it doesn't last long, and then it starts the descent. Then we find the patient will experience some dysphoria, some displeasure, restlessness. They may start craving more of the narcotic, and if they're tolerant to the drug, they get a withdrawal. Tolerance to opiates is one of the fastest, and it develops in as little as 3 days if you're using a regular amount of opiates for that period of time. Next slide. So we're going to go over the approved medications for the treatment of opiate use disorder. These are a little bit medically heavy, and so I don't think you need to know all the details about the metabolism. But what we want to know is methadone. So methadone is a very strong opiate. It's a full opiate agonist, which makes it strong, and the strength makes it very effective. Unfortunately, that strength also makes it has some risk or danger to it. So it's a full mu agonist. You can take it orally. Typically, in an OTP, an opiate treatment program, we give the methadone in a liquid, which would help decrease the diversion. And I'm sure in the correctional systems, they would probably do everything they can to reduce the possibility of diversion. But unlike the short-acting opiates like heroin and pain pills, the methadone goes up very slowly and it goes down very slowly. So by going up slowly, you're less likely to get the reinforcing effects of intoxication. There are people who can become intoxicated on methadone if they take too much or they double their dose. But again, the way the OTPs are set up, the patients don't really receive uh, take-home doses until it's been demonstrated that their behavior is safe. Um, there are some increased deaths from methadone in the last several years. Most of that increased death is not from opiate treatment programs, but from methadone prescribed by pain doctors. Methadone is a very good pain reliever, but people who have died from methadone typically have a concomitant ingestion of alcohol or benzodiazepines. And so you have to be both in the OTP and even in the prison. When I worked in the Nevada prison, I did hear inmates, or we had some inmates who were using Pruno with that. So I think you'd want to obviously advise the patients who go on methadone about the interaction. Methadone also holds people in treatment better than buprenorphine, again, because it's stronger. And the other thing I think that's a significant factor is methadone is inexpensive. So when I see patients and prescribe methadone to them, I basically say your goal is to take the lowest dose that makes you feel normal, not craving opiates, not using opiates, and not having opiate withdrawal. We usually start them at 30 milligrams. The dose range can vary. Again, methadone being strong can be used in patients with chronic pain. And so if you have somebody who kind of got into opiate exposure because of chronic pain, the methadone may be a better choice than the next drug, which is the buprenorphine. Next slide. So our second drug is buprenorphine. Methadone's been out since the 60s. It was actually invented in World War II by the Germans when they ran out of morphine. And you do want to think of methadone as having a potency roughly equal to morphine. Very strong drug. Buprenorphine, on the other hand, is a very safe drug. It's not as strong as methadone. It's a partial mu agonist, which means it activates the mu receptor, which is your pain receptor, partially. But it has a very high affinity for the receptor, and it'll usually displace other drugs if they're on the receptors. And so because of that, the patient has to be in withdrawal before they start buprenorphine. And if they're not, or if they have opiates in their system, it may cause what we call a precipitated withdrawal. It's again, it has a high receptor affinity. It has even a longer half-life than methadone, averaging about 34 to 36 hours. Um, Most people that have withdrawn from a methadone inappropriately, which would be a rapid withdrawal, and buprenorphine, say that the methadone withdrawal is more serious. The correct way to withdraw from methadone is to go up very, very slowly and to go down even slower. So if you talk to people that withdraw from methadone very gradually, they don't go out on the streets and tell people methadone is worse than heroin, because it isn't. The buprenorphine does require a special waiver from SAMHSA, a government agency, and that would be one of the requirements if your prison's going to open up opiate treatment, that you have a waivered provider. It could be a nurse practitioner, PA, or physician. Next slide. Naltrexone. So we do have in Nevada, we've had some people leaving the jail system who have received an injection of naltrexone. Naltrexone's been around for a long time. It's basically, think of it as a long-acting Narcan. So naloxone or Narcan reverses opiate overdose. Naltrexone is kind of like, if naloxone acts for a few minutes or half an hour, naltrexone acts for days and weeks. There's no opiate in naloxone or naltrexone. They're non-opiates, so the naltrexone is a long-acting mu antagonist. So it basically takes over the mu receptor, your pain receptor, and it blocks it. So it blocks it with a surmountable blockade. So the naltrexone can be overridden, but that's very dangerous, and people that do that have a tendency to overdose. If the naltrexone is given before the person is off of opiates for a substantial period of time, like a week or 10 days, it can also precipitate a withdrawal. The oral formulation is not recommended except in particular settings where there's heavy supervision, because the compliance is low. And so because of that, the SAMHSA and other groups recommend the injection of the naltrexone, which is Vivitrol. Next slide. Oral naltrexone is not expensive, but again, it has a low retention rate. It need to wait to start it. It does have some effect and benefit on reducing cravings, and it can also be used for alcohol use disorder, because alcohol has metabolites that affect the opiate system. The injectable Vivitrol or injection naltrexone is 380 milligrams a month. You can start that when the person's still incarcerated, and may help with certain populations. Sometimes some of the recovery programs have difficulty accepting patients on MAT, and so the naltrexone is a better option. And again, the retention rate with naltrexone is higher with the injection than orally. Next slide. So there's been a number of studies that show that methadone started in the United States in the 1960s in New York City, but there's been a number of studies that have proven that methadone reduces death rate and it reduces crime. And so I think there's a benefit to our entire society if we can reduce crime. And methadone has been shown in a number of studies to do that. The other thing it does, if it's at a pretty substantial dose, it can block the euphoria. And so if the patient is kind of still using smaller amounts of heroin, it can tend to block that. And at some point, there becomes the use of heroin becomes kind of ineffective for the person who's on methadone. They also reduce their medical utilization, which would be important whether they're in the emergency room in the community or they're in the clinic or the medical setting in the prison. It also reduces transmission of Hep C, HIV, infection, illness, because the patient's not injecting. And again, to emphasize, it reduces the death rate from opiates at least 50%. Buprenorphine can be given, it's a sublingual. If you swallow it, it doesn't hurt you. It's just less effective. They do have an implant of buprenorphine now, but that's only for a year. and it's also more expensive. And then they also have an intramuscular injection, which I've had some experience with. It works fine. But again, those are kind of expensive because they're new. The difference is buprenorphine can be prescribed in an office. If the physician is waivered for buprenorphine, then they can go ahead and provide it. And so one of the benefits of buprenorphine is you don't go to a opiate treatment program, and you can be a primary care doctor who prescribes it. And so we're trying to mainstream it into mainstream care. It does have less pain relieving capacity compared to methadone, and there's a maybe 5% of people that I've seen that the buprenorphine is just not strong enough for. Either drug can be used in pregnancy. The baby has a little less risk of fetal abstinence syndrome with buprenorphine compared to methadone. Next slide. So again, I mentioned initially that I've never met an addict who wanted to be an addict. What I frequently see is somebody who grows up with, say, an alcoholic parent. The father or the mother may have alcoholism, and so the patient says, I'm not gonna use alcohol," and they avoid it. But then through whatever process, whether it's a sports injury and the doctor puts them on an opiate, whether they want to take some risk and with their friends and use opiates, once they start on an opiate and they have this genetic susceptibility to addiction, which really explains about 40 to 60% of the risk of addiction is actually genetically driven. So I think of it as the brain is a fertile soil, and once those opiates get placed in there, they're going to grow things that the patient doesn't want to have grow, and they're going to take over control of your system, and in a way hijack your brain. We do know that drug addiction is the most stigmatized condition from a World Health Organization study. And we do look at terms like junkie or drug abuser, abuse, as kind of derogatory terms. And so one of the moves from the ASAM, American Society of Addiction Medicine, is try to really look at the language that we use with patients who are addicted, so that we really think of them more like diabetics who need insulin, hypertensives who need blood pressure control. Um, there was some recent article on surveying people with heroin addiction who had been in the hospital, and the patients can report that they have, depending on the provider, they can report different experiences, some of them not pleasant. Next slide. I think Carl went over this, and this is very, very important. I think even this would be, I think, the first place you could do, and I don't think this should be very controversial, but if the prisons and the jails were to distribute naloxone at discharge, we now give it to every person with opiate use disorder that we see. We also give it to people, the families, and frankly, we give it to anybody. There was a study of how they distributed naloxone in Massachusetts, and so they did it county by county, and they monitored the death rate, and it reduced the death rate with the distribution of naloxone in the county. It reduced the death rate from opiate overdose about 30%. So that's pretty substantial, and I think we're trying to really get people in the community to have naloxone. I've given some to some of my patients, and they've used it on other people. Obviously, most people use it on somebody else. Next slide. I looked at the guidelines for the American Society of Addiction Medicine, and they have some specific guidelines for correctional facilities. And then the National Commission on Correctional Healthcare also has guidelines, and both of them support using MAT in the correctional facilities. There has been, I think, some of them that are using it, and Carl obviously worked very hard to get it in his program. Right now in Nevada, things are a little different than they were 10 years ago. The jails now will allow patients on methadone to stay on methadone. But if the patient is headed for prison, then they're basically forced to withdraw from methadone. And so this is back to what Carl was talking about with the forced withdrawal. That one is, not very humane. Two, it's not medically recommended. And three, if you're on methadone and you're doing well and you get incarcerated because you obviously did something, you're going to think twice about getting back on methadone the next time. And so that may be a discouragement. The forced withdrawal may be a discouragement for future MAT use. There are some randomized controlled studies that show, like in Rhode Island, where the patient is on MAT at release, that they have a better retention in addiction treatment. Right now in Nevada, we do get some patients who are referred by the criminal justice system to our program. Some of them choose not to use medication. They may have a number of years and want to see how they do without it. I leave it open on patients who don't request medication. On the other hand, I've had some people released from prison or jail who had some abstinence, but were still craving and felt they were vulnerable. And so one of the most important things is to try to get the patient to be honest with themselves. Next slide.
Dr. Kaiser, I want to keep you conscious of time. So we only have about 5 minutes left, and I know we want to leave some room for questions. So if you could kind of hit your highlights, and we'll move into questions whenever you're ready.
Thanks, Chrissy. Thanks very much. So when I was the prison medical director, I built the system. We got the state of Nevada out of 2 federal lawsuits. And actually, I didn't leave the prison because the budget was busted. But I do salute all of you for what you do for the patients and the people who are dependent on addiction. You do have to have a little bit of a thick skin. And as you can see in the box, the Senate did pay our prison health bills. Next slide. So I think the real challenge is how to do this. Having worked in a prison, I think there's a heavy weight of exertion, of inertia. And so the prison, getting the prison to move on something is real challenging. Next slide. In Nevada, the prisons changed because of federal lawsuits. And I do understand, although I'm not familiar with them, that there are some current lawsuits apparently having to do with MAT treatment in the correctional systems. But I do think there are some other questions, like should the inmate receive MAT if they're going to be in there for 20 or 30 years or death row sentence? The diversion, I think Carl went over that quite thoughtfully. I do think on a prison yard, there may be some challenges to confidentiality. I'd be interested in what Carl has to say about that. And the other issue that we had in Nevada was the staffing of prisons. And so getting providers who are knowledgeable with methadone, buprenorphine, and naltrexone, and our waiver to prescribe naltrexone. This is just a little bibliography, but if you have any questions, you can send me an email or contact me through BHG. Thank you.
Nicely done, Doc.
So we've had a question come in through the chat, and I'll throw this out to either of you to answer. It says, how do you deal with those who are released and join an MAT program, and yet the parole officers are telling them that they have to be off everything in order to stay out of jail?
Doc, you want me to take that one first?
Oh, actually, I got a little experience with that. So I think I think we did write a letter to a judge who wanted to put everybody on naltrexone. I think it's an educational process. I mean, sometimes I tell the patient, just go over it with them and have your parole officer or your probation officer contact me, and we can try to go over the reason for the medication. But again, that's part of the stigma of the medication, and part of this, kind of like the former inmate is a second-class citizen. They wouldn't do that if it was insulin. They wouldn't do that if it was cardiac medications.
Exactly
right.
right.
And if I may piggyback on that just a little bit, I think it's also important, as the doc just said, MAT meds, it's not a one size fits all. I think it's very important that, we do treat these individuals as individuals, and they've got a say in which medication they think would work best for them.
That's very important, Carl, because what happens is the patient may have prior experiences. They may have prior experiences with methadone, buprenorphine, or naltrexone. Some people don't tolerate the Suboxone combination of naltrexone with naloxone. And so there, each patient is an individual, and you try to match the best treatment with the patient's basically their medical situation.
Agreed.
Thank you both for that response. I think advocacy is key, right? So another question I'll throw out to you guys for either of you to answer is really, what do you recommend as a first step? I think this can sometimes feel a little bit like a big project to take on. For those out there that might be considering this type of programming, where should they start?
By taking some deep breaths. I will tell you, if I may just jump in, our program here, it literally was a 2-year project. Again, we began with Narcan, and we did identify and continue to identify folks that are, high risk regarding OUD. And we do provide them training on the Narcan to include, I think this is important, it is an important piece where, as the doc said earlier, typically a person that is overdosing from a suspected opioid, they cannot administer their Narcan to themselves, right? So the training that we provide does provide some advocacy for them to, be open and honest with your friends and family. And here's the literature on where my Narcan is and how to administer it. So it starts there. And then once we rolled that out with the Narcan, I really underestimated the stigma, the stereotypical thought processes. And it literally took, that proactive communication, internal discussion, extending out to the community, where we were able to change some minds and provide that education where, again, I say half jokingly, take a deep breath, but it is a marathon and not a sprint. But this type of webinar is proving to us that, our thought process is changing right before our eyes. So just be committed to it.
Yeah, if I could just back that a little bit, I think the naloxone, the Narcan is definitely the first step. The second step would be to look at those people who are being discharged, who are at the high risk for death. And so, maybe you could get your system to consider some initial treatment for those people so that we can reduce the risk of death. I think that's probably the next step. Whether your prison does it, totally like Rhode Island, or whether they do it piecemeal, that would be an area to target.
Mm-hmm. So we've had another question come in. What are some symptoms patients and programs should be aware of for those newly prescribed methadone or Suboxone?
I'm not sure I understand the question. What are the symptoms? That would be like withdrawal symptoms, or symptoms of intoxication, or symptoms of the medication effect?
I'm going to guess symptoms of medication effect for somebody that maybe is not familiar with MAT and is now engaging with MAT patients. But Heather, who submitted the question, feel free to chime in with clarification if that's not what you meant.
What we do at OTP is the patients medicate daily at the OTP with methadone for the first 90 days. And the nurse assesses them. They do impairment assessments. Sometimes they have them blow for alcohol. They can do drug screens. If the patient has any degree of intoxication, sleepiness, drowsiness, they do an impairment assessment and see if the patient's still safe to take methadone. So I think we're vigilant, obviously, and then they take the medicine in front of them, but we're vigilant. Methadone peaks in about 2 hours. And so we try to monitor people as best we can to be sure they're not taking too much. So
for clarification, she chimed in and said that courts will often get reports of drowsiness for participants that are on MAT.
That's a tough one. I just had a patient who was pregnant on methadone, and she was on a big dose. And her treatment facility reported she was taking a nap in the afternoon. On the other hand, having worked a little bit with pregnant women, sometimes they like to take a rest in the afternoon. And so, was it too much methadone, or was she just fatigued from her being pregnant?
Mm-hmm. Yeah, if I could chime in on that, I would just say the most important thing in that situation is really coordination with the provider, with the OTP, and that if you're observing that, just don't feel like you're dealing with that on your own. Work with your partner to get to the root of what might be causing that side effect. So I'm going to wrap us up with one last question. If you could say one thing about why MAT is important and that drug court professionals and correctional healthcare professionals should know, what would you say to that?
Go ahead, Carl.
All right. So I would take it as, enhancing the continuity of care, which will have a direct correlation to a decreased risk of mortality. We can avoid the withdrawal while they're incarcerated. And when they are, released from custody, I call that post-release. They don't take a lapse in their treatment. I do want to chime in too that I think that it's important for all of us to remember that medication-assisted treatment is exactly that. The medication regimen is absolutely imperative, but so too is the counseling component. And I think it's important for the drug courts. In our case, we call it the problem-solving court. There's got to be a continuation or availability of that counseling psychotherapy.
I couldn't agree more. I think each patient, somebody's brother, or sister, or father, or mother, or child, and I had one patient who was about 22, and he'd been to 6 funerals of his friends, and so to me, that's a huge loss of life, and it's certainly a preventable. At some level, it's a preventable loss of life.
Mm-hmm. Agreed, Doc.
Excellent answers. Thank you both so much. And thank you both just for the incredible work that you do and your contributions to what we do. And thank you so much for being here with us today and sharing your experiences.
Absolutely. Thank you very much. I appreciate the partnership. And I know we talked about it early on. Thank you all for taking the time out of your day to join us.
Ditto.
And thanks to all of you that attended. And I just want to remind everyone that came today that you will receive an email with the slides. And you may have seen a pop-up during the presentation today, an opportunity to download it. But it will also come to you by email. And yeah, thank you so much. Thanks, everyone.
Bye-bye.
Thank you.